when performing a new patient evaluation, we like to use a person-centered care evaluation flow. And the purpose of person-centered care is to establish a connection with that person and treat them holistically versus as a diagnosis or even as a label of a patient. And by doing this, we're going to increase the chances that we form a really good connection with the patient on the first visit, maximizing our patient alliance, and also it sets us up for a really nice clinical reasoning process where we can come up with a really good plan and hopefully increase the chances we get an optimal outcome with our treatments. So we're going to go through the basics in this video, and then after we get a summary of it, we're going to have an individual video for each component so that we can really break it down. So just looking at it from big picture perspective, we have a subjective portion, an objective portion, and the intervention portion. To start off our visit, we always want to start with a warm welcome. That includes meeting the patient out in the lobby, using a handshake if it's appropriate, making eye contact, calling them by name, also asking them what name they prefer, can all be ways to establish that connection right off the bat. As we get into the room, one of the first things we want to do is establish patient expectations, what they're expecting for today's visit. We can get some of that information by asking if they've been to physical therapy before. And if they have, they've likely experienced an evaluation, they've experienced treatment, they've either had a positive or negative or neutral experience. So it's good to know that before we start the process of getting information from the patient. Then we're going to do our subjective examination, and we'll get into in later videos exactly how we get the information that will be most helpful for us and to really listen to what the patient is saying. S1 is summary 1, and this is where we confirm with the patient the information that they gave us during this subjective evaluation to get us on the same page. So taking those major points that they gave us and that we questioned about during the evaluation, summarizing for them so that they can say, yes, that's exactly what's going on. Or actually, I forgot to say this. Or actually, remember I said this. It gives you that moment to really get on the same page. Moving on, with permission from the patient, you're performing an objective examination. As you're going through the objective examination, you're explaining what you're doing so the patient knows what's going on. And then S2 is summary 2, and that's where you summarize your objective findings to the patient. So whatever range of motion, strength, special tests that you performed, you can give that information to the patient in terms that they understand. Here's what we found, and because of these findings, here's what I think is going on. And that's when we get to Giffords 4 or G4. Those are the 4 things that patients really want to know. It's the real reason they're coming to see you, is to figure out, number 1, what's going on. Number 2, what can you as the clinician do for me to help me? Number 3, what can I do for myself? And number 4, how long is it going to take me to get over this condition? And so that's your opportunity to really show the patient that you understand what's going on and what it's going to take to get over this issue or this condition that they're experiencing. We always want to try to give the patient some sort of treatment or some sort of symptom modulation when possible. So that leads us to the intervention portion, and we're starting with treat, retest. One of the impairments that we found in the objective exam, we're going to want to try to treat, and it doesn't matter if it's a modality or manual therapy or an exercise. Whatever you think is most appropriate based on this patient and has evidence to support it, and seeing if that changes one of their impairments. So using manual therapy to improve joint range of motion or using a modality to reduce pain are examples of how you could use treat, retest. Based on response to treat, retest, we'd want to follow that up with a home exercise program that's individualized to the patient, usually building on that treat, retest. So if a patient has limited shoulder range of motion and we do a shoulder mobilization, and their motion improves and their pain reduces, we would want to give them a similar movement or exercise to try to reproduce what we did in the clinic. Finally, to close the loop, we want to ask an open-ended question to the patient about questions they may have about this whole process. So the best way to do this is to say, what questions do you have for me? Rather than saying, do you have any questions? The do you have any questions usually elicits a yes or no answer, and in the majority of cases, no. But if you ask open-ended questions, you'll get more information. So we want to make sure the patient really understands everything that we talked about today, because it's going to increase the chance that they're going to follow through with your plan. Finally, you want to warm close. This usually includes walking the patient out to the lobby, making sure that you're handing them off to the scheduler or an aide or anybody else that may assist them getting follow-up visits scheduled or getting their home exercise program handouts or whatever it may be, but making sure that you close that visit strongly. And if you follow this process, the chances that that patient is really going to connect with you and you with the patient, and that you're going to get a solid plan at the first visit is much, much higher than having a disorganized, non-person-centered approach.